thank you very much for the invitation here to speak with you all. So I'm a health economist at the University of Aberdeen, and my goal here today is to give you an introduction to health economics, to explain what the key concepts of health economics are, and hopefully convince you that health economics can be a useful and helpful tool within your practices and within making the point around how do we demonstrate value for money of new healthcare and dental care technologies. I'm going to speak a little bit about some of the specific challenges in dentistry, and then I'll talk a little bit about the health economics analysis plan that we have in place for the PIP study, which you've already heard a little bit about from Professor Manocci. So health economics is the intersection of health, dental care, in this case, dental outcomes, and economics. So it's around understanding the fact that whether we are patients investing in our own dental care, whether we are healthcare systems deciding what technologies to provide, we all face limited budgets. So we don't have an indefinite amount of resource available to pay for healthcare. We do, however, have a large amount of dental need, and we've seen that earlier on with caries in particular being the most common non-communicable disease worldwide. So we have this problem of almost unlimited dental need, but very strictly controlled budgets. So we have to make difficult choices around what treatments we provide and how we allocate dental budgets. So we need to think about the concepts of efficiency. How do we allocate those scarce resources in the best way that maximizes the dental health gain for a fixed, limited budget? So we need to think about what things provide the best value for money, and that involves difficult choices. So that means some things cannot be paid for by healthcare systems, and we need to decide where we get the most bang for our buck from our investments. So healthcare decision making is around, should we implement a new technology? And I'm going to speak a little bit about how economics and health economics can help you make those decisions and help you identify the evidence that you need to inform people who make funding decisions. First of all, we need to know if things work. Clinical trials, clinical trial evidence, probably not very controversial. We need to know if patients value the interventions, the treatments, the health technologies that are being considered. It's all very fine for something to work, but if patients don't want it, don't want to accept it, then it's not very much use. So we have to understand patient preferences. We can do that in many different ways. I'm going to speak about discrete choice experiments, which are an economic way of understanding some of the issues around patient preference. And we're going to talk about value for money, cost effectiveness. We need all of these things to make optimal resource allocation decisions. We need to understand all those components to get good use for money from healthcare budgets. I'm not going to go through this slide in much detail. It's a summary of the different types of economic evaluations you can have. Key points here are that, well, obviously we measure costs in terms of monetary values, and there are different ways we can measure outcomes. We could measure them as cases of caries avoided, cases of tooth loss avoided. That would be a cost effectiveness analysis. We could use quality of life or oral health specific quality of life. That would form a cost utility analysis. And the integration of monetary values to understand the weights and the amount of value that people place on different technologies can be integrated in a cost-benefit analysis. In dentistry, we have a particular problem. So Professor Manocci mentioned this earlier on around using questions such as the Euroqual 5-dimensional scale, which asks you about mobility, self-care, and so on. However, it does have the advantage of being consistent across the healthcare system. So you could, in theory, compare any allocation of resource using a QALY. That's great, fantastic, but the problem is it's not sensitive in dental care, and specifically not sensitive in caries. Two reasons. It has limited value for acute conditions. So for example, if you were to use a QALY, you would probably never pay for dental anesthesia. probably not something most people would value, or probably what people would value very highly. So we don't necessarily get outcomes that are aligned entirely with patient preferences. We can do that, though, through cost-benefit analysis. We're looking at willingness to pay, which is a direct valuation. So if we ask someone what's the maximum amount of money you're willing to pay for treatment A versus treatment B, we can understand how people value it. It's the very same as going to a shop. The other advantage of that is that we can incorporate multiple outcomes. So we're not reliant on one single outcome of care. We can get willingness to pay values for short-term pain. We can get them for long-term risk of tooth loss. And we can integrate all that together within one analysis. Of course, there's negatives with that as well. There's a generalizability issue. We couldn't, for example, compare treatment allocation of money for caries with periodontal disease. And of course, there's an issue with putting a monetary value on health. Discrete choice experiments. So first of all, what are they? They're a hypothetical survey. They value goods and services, and the value of those goods and services and treatments and health technologies is based on the value we put on its component parts. So take an example of deciding how we're going to get to the Septodont Global Pulp Summit. We might value different things when we're choosing our mode of travel, we're choosing our airline. We might value check-in service, entertainment available, legroom, food and drink, reclining chairs, and so on. The list could be endless. But we value each of those components individually, and we can sum them up to understand the value we place on the service as a whole. Of course, we don't consider ticket price for coming to this conference because thankfully, Septodont have paid for us all to be here. But the key point that we're making is that discrete choice experiments allow us to make trade-offs between different attributes of care, different component parts of a health technology, so as we can understand how people value the whole process. This is an example of what a discrete choice experiment looks like. You could compare two different packages of dental care. This is an example from one of the studies that was led by Professor Clarkson in Dundee. We compare two different packages of care for periodontal treatments, prevention, and the value of those different packages is dependent on what you get, perhaps who provides that, what your outcomes are clinically, what they are aesthetically. And you can combine all of those values together to get a total monetary value of willingness to pay. The next concept is decision modeling. So we need mathematical models which are designed to mimic the real world. Because if we run a clinical trial for caries prevention, for example, we might show differences in early stage caries, moderate caries within our trial. But that's not the whole story. We need to understand value over a full lifetime horizon. So, for example, what are the costs downstream? What are the costs of extractions avoided? Implants that people might have after an extraction. If we have effective, good value treatments up front, even although they're expensive, we need to understand the downstream value. And it's very unusual that we would capture all of that within a trial because it's just not plausible to run a trial for 20 years. So decision models can help us make that link between intermediate outcomes and final outcomes. They facilitate multiple treatment comparisons, so we can use evidence synthesis, systematic reviews of all the available evidence to understand what the most optimal pathway of care actually is. They're adaptable to different settings, so we could run a decision model for France, one for the UK, one for anywhere in the world. And importantly, we can quantify the remaining uncertainty, so we can understand better what we don't actually know in terms of longer-term outcomes. So here's a simple example. If we were to consider a question of cost-effectiveness of different approaches for caries prevention, key outcomes are, well, do we have caries or not? We might get that information from a trial. But we're also interested in treatment need. What treatments might people have? Do we keep people caries-free for longer? There might be a value of keeping people caries-free for 5 years compared to 3 years. That's a good outcome as well. So we need to include that within our models. And ultimately, we're interested in tooth loss. That's the final outcome that incurs the biggest, that's probably what patients want to avoid and incurs the substantial costs, both in terms of the initial tooth loss extraction, but in terms of downstream as well. So some examples of economic evaluations of prevention and treatment for caries that I've been involved in, led by Professor Clarkson in Dundee. Let's say we're starting off considering people at risk of dental caries. We might be interested in what treatments do we provide. Do we provide high-dose fluoride toothpaste as a preventative measure? And how do we understand the value of that prevention? Further down the pathway, do we use selective caries removal or full caries removal, complete caries removal? Further down the pathway again, are we interested in pulpotomy or root canal treatments? So all of these are questions, individual questions along a complete pathway of care for a patient with caries. We're using methods like decision modeling to map the future, map what it means if we can prevent caries now into the need for these treatments. Hopefully we never get to the point where we have to do the PIP study because we've had very good prevention up front. Probably unlikely in reality, but we can use decision modeling to map that process. Obviously, we need clinical effectiveness evidence, which treatments work best. We can use discrete choice experiments to understand how patients value treatment. We are interested in understanding the cost to healthcare systems. In the UK setting, that's the NHS, but also to patients, their families, society as a whole. People take a lot of time off work managing caries, going for treatment, and dealing with dental pain. And there's also an increase in interest in sustainability, and by that I mean environmental sustainability of the treatments that we use. So we can synthesize all of this within an economic evaluation. So for the PIP study, we're considering adults with premolars or molar teeth who have signs of irreversible pulpitis. Should we use pulpotomy or root canal? And within this setting, we're considering costs. Upfront costs of the intervention delivery, which of course will involve Biodentine. We're looking at short-term healthcare resource use. How many times do people go to their dentist for the treatment? Do they need to come back for pain? And then ultimately long-term care requirements in terms of risk of tooth loss into the future. We're also considering the benefits. Clinically, do we have vital teeth? Quality of life, patient preferences. What do people value? Which components do they value most? Do they value avoidance of short-term dental pain more? Or do they value a small change in the risk of needing an extraction into the future? And again, these are all questions that we're aiming to tackle from an economics angle. We've seen these slides in the earlier presentation. It's a summary of the economic outcomes. And just, again, a very simple hypothetical example of what the PIP study economic model might look like. Do we have treatment success or do we have treatment failure? We want to keep people in that treatment success state for longer. We don't want them over here where they incur high costs, poor outcomes. But even if they go here, we want to try and either have the tooth retained and retain that tooth for longer, or there might be an extraction. So we want to map that whole pathway of care and at each point understand patients' values, quality of life, and cost. Some of the specifications for the model. When I talk about costing, I'm talking about intervention costing. So it's important with these decision analysis models to understand that even although an intervention may well be highly costly to deliver, that cost needs to be considered alongside the downstream costs as well. the downstream cost savings that might be avoided from, as I say, complex root canal treatments, complex extractions, hospital care, and so on. We're looking at treatment costs up to 1 year from the trial, and we're also going to model them into the future. We're going to try and understand the pathway of disease as a whole, and we're going to use data from the trial to help us do that, as well as from external registries. The treatment benefit will come from the trial, and that will be modelled forward. In terms of outcomes, we are going to report generic QALYs, and this is one of the key issues that we still have to convince funders about, is QALYs don't work in dentistry, because you're talking about length of life, and for the majority of cases, I think we can agree that dentists aren't going to lead to people dying. But we do still have to do this. It's part of the requirement, but we're also going to expand beyond that and look at valuation of dental outcomes specifically. This is an example of what the discrete choice experiment from the PIP study might look like. We could compare different packages of care. So let's say they differ in terms of their waiting times, the number of appointments and the length of those appointments that you need with the dental care professionals. Do you have pain at 1 week or not? Do you need retreatment within a year? And then we'll also ask people how much they value each of those different packages of care. So these questions, there'll be multiple questions like this asked to people within the trial and from the general population. And then we can use those willingness to pay values to help us understand the overall value for money for pulpotomy and for root canal. So that's where I'll leave it. Thank you very much for listening.
This is now the economy session, economics. There are no images of teeth involved. So I'm sorry for that, and it will continue like this. So this is now a little bit of hard work for you after the coffee break. I think Kerstin will probably deliver some more. Okay. There will be some more images of teeth and pulps later on, because someone said the pulp looks sexy. We can't deliver that, I'm sorry. So what I will do, I will take up the ball where Dwayne just left it, and I will talk about a little bit more the specific data we have in particularly endodontics on health economy. And you will see that, unfortunately, there is not too much, and this is also where I will begin. So I will introduce what do we have. I will then go into some of the details, vital pulp therapy, saving the pulp, saving the tooth. Is it really worth it? There are probably not too many implantologists in the room, but they may differ and see the things different. And at the end, I will also slightly go into one topic where it becomes a bit more relevant for your practices, because at the end, a dental practice is an economic entity, and maybe looking a little bit at what we do from an economic perspective is also interesting to you. I would just skip this because I explained it already and jump right into it. Most of you will be endodontists, and you will perform root canals every day, I assume, most of you. And we see, when we look at the numbers, 15 million root canals done every year. This is a lot. When we look at the number of health economic analysis, however, for this huge field where millions and millions of euros are spent, and obviously some of the money is flowing into this event because we are all here now, and thanks to Septodon, we didn't need to pay anything. Despite all this money involved, there's a very, very little data on endodontic interventions and their health economic evaluations. And we just, about 2 years ago, Sascha Herbst, who's also here, and myself conducted a review. At the end, we ended up with only 11 studies in the whole field of endodontics where health economic evaluations were performed. This is really very, very little. There's much more in cariology, there's also a little bit more in periodontology, but the field of endodontics obviously hasn't really delved much into the economic perspectives. And I think it's very important, because at the end, we all want to show to funders, to insurances, to our patients, that what we do is worthwhile not only clinically, but also maybe economically. What was covered in these 11 studies? Well, vital pulp therapy is obviously a big thing. That's why you are all here, and it was also the focus of the majority of studies. Then there was some comparisons, and I will also touch this, of root canal versus, for example, pulpotomy, or versus direct pulp capping. And then there were some comparisons of different root canal approaches, like 1-step, 2-step, and so on. Just to sum it up, before I go into some more detail, what we discuss here is absolutely also valuable from an economic perspectives. Most of the studies speak a very clear language, maintaining pulp vitality. We've heard that from Avi Banerjee before, we've heard it in a number of talks. Using, for example, selective caries removal, and I go into that example in a second, is cost effective. It's not only saving teeth, it will also reduce the long-term costs for what we do to our teeth, what we do to our patients. Retaining teeth is also a cost-effective thing. This is now something the implantologists don't like to hear, and I will cover this at the end of my lecture. So taking all the steps which also Dwayne touched when it comes to caries, for instance, is preventing it, treating it early on, then even treating the deep lesions in a way that we can retain teeth is worthwhile. It comes back to this death spiral you've already seen. And the more invasive we get also in endodontics, the harder the economic balances get, because then endodontic interventions get expensive, like the second retreatment or a surgical retreatment and so on. Then it will be harder and harder to justify retaining the tooth at some point, because the failure risk increases while the costs are also quite high. And then at some point it can easily tilt that, for example, using an implant is maybe the more cost-effective choice long-term. We have a number of the different types of studies we see in endodontics. We have cost of disease analysis. Most of the studies were cost effectiveness studies, where, for example, the outcome was how long do we maintain pulp vitality, how long is the tooth retained in the mouth. These are typical effectiveness measures. There's not much for all of the other stuff we've heard. There's not much with regards to cost utility, because it's hard to measure it. As we heard, QALYs, they don't really work. Even stuff like OHIP, you mentioned that, is in some cases very, very hard to apply, because what we do with our patients not necessarily impacts their general quality of life. We just saw this in a big trial which we published in care homes, where we went into care homes, we remotivated the nursing staff, for instances, and everybody was very happy. The patients were happy, the nurses were happy, the dentists were happy, but the oral health quality related quality of life didn't change a bit. So it's very hard to measure our effectiveness outcomes or our utility outcomes. And the majority of the studies in the endodontic field also looked at all these analyses from a payer's perspective. So what does it cost, for instance, the insurances if it's an insured system, or the patient if it's fully private. Coming to the topic which I was given, saving teeth, is it worth it, in some more detail? Well, I want to go through 3-4 examples with you from the literature. What does the evidence say? Is it worth it? Yes or no? This is quite an old study by now, I have to say. We published it nearly 12 years ago, and it was one of the studies where we focused a lot, and some of you may know this, that before I did a lot in AI over the last years, I focused a lot on deep caries management, where we tried to assess which options do we have for managing deep caries in vital teeth, so not irreversible pulpitis, in vital teeth, and how does this boil down at the end towards patients' preferences, towards the economic implications, and so on. What we used here was a modeling approach, and this was already mentioned. These models, they have, well, a number of limitations, obviously, but they also have a number of advantages, because what we can do is we can take data from different trials, like the ones we've just seen, and we can stitch them together to generate sequences of events which we could never, ever reflect in clinical trials. And you can see the model we used here. We started with a deep caries lesion, vital pulp. You can do, in this study here, we at this point still termed it complete removal, so non-selective removal, or you could do incomplete removal. Please don't call it like this, call it selective removal, but at this point we didn't have the terminology yet. And resulting from that, there was a certain risk, based on the evidence, of exposing the pulp. For the exposed pulp, we then tested either direct capping in this model or root canal treatment, and then you can see that stuff happened. You placed a composite, the composite could fail, the root canal treatment could fail, the direct pulp capping could fail, and even if there was no pulp exposure, there was a certain risk of complications. That at the end led to certain reinterventions, even up to the point in the model where teeth were lost and replaced using, for instance, implants and implant-retained crowns. That's fantastic. That's something you can't reflect in clinical data, because you can, in this study, for example, mirror a time span from, I think patients were 20 years old at the beginning, until they die. So we can look over 40, 50, 60, 70 years. Of course, what we have to admit, the longer we do that, the more uncertainty we have. That's logical because we add uncertainty at every node of these models because every evidence point, every data we use has uncertainty. And the more we put into these models, the more uncertainty we have, of course. You can see these data which we used, failure rates, risk ratios, whatever, to populate the model and to allow the teeth to move through it. And these are the results. These are the results. They're usually shown in such a cost effectiveness plane where you have the effectiveness on the x-axis. In this case, it's tooth retention over time, and the costs for doing that on the y-axis. Ideally, you want to now be on the right and at the bottom, of course, then you're cheap and very effective. And what we can clearly see here is that the one step incomplete, selective removal now, the selective removal was exactly that. It was less costly, significantly less costly, and also much more effective in retaining both pulp vitality and the tooth itself. And you can also see this in the table here. The differences were quite dramatic, especially when it came to the cost. And that was mainly because we were able to avoid direct pulp capping or root canal treatment, all the sequels which we discussed today. So in this case, the economic analysis is a very nice reflection of this death spiral which you've seen before, because we can avoid even entering it and thereby generating all these treatments, which is all fine. This is where we live from these treatments. But these models clearly show that having different levels of invasiveness right at the beginning has a big impact on the long-term cost effectiveness. And that is very nice because by now, after a lot of other publications, more and more clinical data, we have these statements, and you've seen that before. This is the statement of the European Society of Endodontology, which clearly says selective caries tissue removal, this is something as long as the pulp is still vital and there's a high chance, and this is diagnostically challenging, of course, but there's a high chance that it will manage every procedure, we should try and do it. We should not, sorry for Professor Monocchi who showed the nice clean dent in there, we should not try and expose the pulp and clean it up fully, at least not according to the statement. Of course, but you can now say, okay, in my setting I use CBCT, I use different procedures under the rubber dam, and I use, I don't know, Biodentine or MTA, but this is not necessarily what we have in everyday setting. And so for a normal everyday setting as a base case intervention, I would call it, in this case selective removal was at least the better choice from a health economic perspective. What we then did is we said, okay, now that's fine. There are more things which we are empirically driven deciding without really knowing what's the cost effectiveness or the health and economic perspective on this. So this is a second study where we also had deep caries, but in this case we focused specifically on the decision, should we, once opening up the pulp, do direct pulp cupping or root canal treatment. Pulpotomy, this is now more than, or roughly 10 years ago, pulpotomy, we didn't have much data and it wasn't as heavily discussed as it is today. I will show you a study, very recent study on pulpotomy in a second. So these were our two choices. You can see again, we used a model. You can see the model there that we said, okay, after pulp capping, it could either work out or it couldn't. You can somehow miss the detection of loss of vitality and experience necrosis. That could lead to an apical lesion. The apical lesion will aggravate the problems during root canal treatment. We've seen the data before that once you have non-vital teeth and you do an RCT, the success rates are lower. And at the end, you ended up with a number of complications, retreatments, again, over the full lifetime of the patient. This is now the cost effectiveness plane which we generated. You can very clearly see it's a bit different from what I just showed you. It's not such an obvious choice now any longer. What we have here is we have the direct pulp capping here. It's significantly cheaper. And we have the root canal treatment here. It's slightly better if you look at the mean values, but also much more expensive. So at the end, this is now a case where I would say, well, it still favors the direct pulp capping, but it's not as clear-cut any longer when it comes to the decision-making as it was for the decision between the different excavation strategies. Then there's a third study. The study is a little bit a repetition of what we did 12 years ago. We now said, okay, we have deep carious lesions. We have the decision between the different excavation strategies. What should I do? And this is the stuff we introduced as a novelty into the study. What should I do once I expose the pulp? Because this will happen. It's more likely when you do non-selective versus selective. But what do I do? Do I really do direct pulp capping with calcium hydroxide? Do I do direct pulp capping with, at this point, we used MTA? And you can see that, of course, this early decision for what should I do when the pulp is exposed leads to cost differences. And this is now one of the cases where Drain already talked about. It is certain that using MTA for direct pulp cupping will make this initially more expensive. And the question is, can we and should we afford this? Is it nevertheless maybe in the long run cost effective because we save costs later on for complications for retreatments? And using a model, we could show exactly that. We could show that using MTA, this is the green stuff here in this case, combined with selective carious tissue removal, so not exposing the pulp, and if you do expose the pulp, please place MTA, that this is not only the most effective choice in this case, it was also the less costly choice. So these 30 or 40 euros more for using a different material initially were well invested because in the long run, you're saving all the retreatments and the associated costs generated from them. And this is the last study I briefly wanted to show you. This is a more recent data, as I already said, where people looked, again, using a model at the decision which we have discussed here in the room quite a lot today, root canal treatment versus pulpotomy, in this case, for teeth with irreversible pulpitis. And what is expected, but now we are really getting into a decision problem, the pulpotomy was cheaper, using different data sources, but of course, initially the pulpotomy was cheaper. They, for example, had these values here for the US. They did it from a US perspective. But what they also showed is that the root canal treatment was better. So now there's exactly this trade-off which we already heard about. What are we willing to pay to retain teeth longer? What is the additional money we want to invest to be more successful? And this is something we, in these studies, reflect using these curves, the so-called willingness to pay analysis, where we plot on the x-axis the money you are all willing, or our patients are willing to invest in one additional year of retaining teeth. And you can see that the more money I'm willing to invest, the more likely it gets that root canal treatment is acceptable. This is the probability that this is cost-effective, acceptable, which is a quite hard to grasp concept. But at the end, what it says is, at some point, if you are willing to invest money, it doesn't matter too much that something is more expensive because the clinical advantage of a therapy gets more and more important. And this is exactly shown here. So these these willingness to pay analysis, they are somewhat informing us about how much resources we need to invest for certain outcomes. And they are also informing us about the uncertainty involved in many decisions. And this is something which is extremely important in health economics. At the end, it's in, I would say, 60 to 70% of the cases not very clear at the beginning that something is obviously the better choice. In many cases, it's exactly like this. Something costs money, something has a certain outcome, and now we need to decide, stakeholders, insurers, patients need to decide what do we want to do with these data. So most of these analyses are rather informing us about the uncertainty involved and about the trade-offs between clinical effectiveness and costs, and they don't help us with the decisions themselves. That's still something we need to do, our patients need to do, or insurers need to do. Now I want to very briefly in the last minutes, and this is blinking like crazy here already, although I still have 3 minutes, I think, or 2.5. Now I would very briefly touch something which Septodont has developed, which they invite you also to approach them. It's something where you do an economic analysis, in this case, of different ways of managing deep caries for your practice. And I just want to briefly showcase how this could work. And this is not a Markov model, so it's not overly complex, it's Excel. So we can understand what's happening in this model. It's still a model, it's not too advanced though. What you have here is you have the costs for materials and the time involved when managing a deep caries lesions. For example, in this case, the first treatment intervention is this biobulk fill, which we heard about today with Biodentine. There are certain material costs, there are certain times involved, so at the end there's a certain investment of resources. Now what Septodont did in that table here is they also have other alternatives, like for example the sandwich technique, which we've also seen with different materials, or even the root canal treatment, or even the solution which I mentioned already, extracting the tooth and placing an implant. So it's more on the side of the implantologist again. So again, different resources, massively different resources invested in these different treatments. And what you can do at the end then is you can take that for your practice and calculate how much should I charge for my patients, how much benefit does my practice and my patient have from different interventions? And for the first time, and that's also why Septodon is interested in this, for the first time you get an informed way of understanding the true different economics of these treatments. And what we played around with this a little bit up front. What was quite interesting is that in various scenarios, the quite, you could say, more expensive Biodentine, because there's a price tag to the Biodentine, the more expensive Biodentine was a good choice from also the economics of the individual practice. We've heard a lot about it being a good choice for our patients because it works. It's a material which is clearly evidence-based working, but it is also working when you organize it, when you tabularize the data for your practice. So let's try it out. We didn't put any price tags at the end or any resource investment at the end because it will heavily depend on the setting, on the costs involved, on the fee items for your certain country. But it's available, and I think Septodon is very happy if you want to approach them. I at least liked it because it's boiling down all this kind of theory to your individual economics in your practice. Now it stopped blinking. Now it's not red any longer. This is unfair. Now it's green again. This is okay. I'm done, so we have a little bit more time in case there are questions. Let me maybe conclude my brief introduction into this topic. What is very important is to understand all the stuff we are discussing today is not only clinically valid, it's also economically valid. This is something we also need to explain to funders of research, to insurances, and of course to our patients. The sentence here, endodontics need to prove its value. That's also important. For all the academics in the room, think about cost effectiveness studies. There are people who can do this. I think we are both happy if you approach us. I think we need to do more of that. Secondly, most of our analysis in dentistry, as always, but particularly in our field of dentistry, are limited when it comes to the certainty of data, the certainty of evidence, but that's fine. Nevertheless, we can at least make clear what kind of different factors in our decision-making play what kind of role. We can make considerate decisions and not only rely on our gut feeling. Vital pulp therapy can be economically worthwhile for your practice, and you can assess this on your own. And at the end, and this is why I'm so happy that you did this, you need health economic literacy. Otherwise, you don't understand these analyses. And I think they will become more important. Same as I do the same when I talk about AI. This will also become more important. And you need to understand these things. So thanks for inviting us to explain a little bit about this fringe topic of economists and economics. Thank you.